Dear Chairman, dear colleagues, I would like to thank the organizing committee for this kind invitation. I'm the old interventional cardiologist. I'm the last period. However, I'm still alive. So, bicuspid aortic valve is a common congenital anatomy that affects 0.5 to 2% of adults, with a male to female ratio of 3:1. May develop as isolated aortic stenosis, aortic regurgitation, or both, in a rate during follow-up from 12 to 37%. Aortic aneurysm has been reported in 20 to 40% of patients with bicuspid morphology. However, this aneurysm may be seen without or with coexistent aortic valve pathology. This is the main classification for bicuspid valve by Dr. Sievert, according to the number of the rafts as type 0, type 1, and type 2. Today, bicuspid morphology are much more frequent in Chinese and maybe in Asian population, TAVI, than in EU or USA TAVI patients. In the Venus trial, the incidence of patient screening for bicuspid morphology from 2014 and later on is close to 50%. But tomorrow, bicuspid valve will be much more frequent in EU and maybe in US TAVI patient than today, because bicuspid valves are more frequent in younger patients. What's the potential problem for TAVI in patients with bicuspid morphology? This valve often is heavily calcified, so sometimes we have incomplete valve expansion, paravalvular leak, and annulus rupture. Frequently is associated with ascending aortic aneurysm, so there is a risk for rupture and dissection. Finally, the oval shape of valve area leaves a space for paravalvular leak, and we don't know at this time the long-term durability of these devices. For all this reason, bicuspid morphology has been excluded from randomized trials, and there is a relative contraindication for TAVI according to the guidelines. Early pivotal trials excluded patients from bicuspid with bicuspid aortic valve stenosis. The use of the first-generation bioprosthetic valves has shown high rate of paravalvular leak in bicuspid morphology and a tendency for more stroke. This is a series from reported patients from 2010 to 2014 using the first-generation devices. The device success rate, it was around 90%, and the degree of more than mild aortic regurgitation ranged between 20 and 30%. And of course, it was an increased need for pacemaker implantation. In this series, both at that time, valves type were used, balloon expandable and the self-expandable devices. This is the first. May I have this, please? Okay. No, the first one? Okay. So this is the first bicuspid aortic stenosis performed in our institution in 2008, with Professor Cribier. It was a bicuspid aortic stenosis. You can see the pre-dilatation. Next, please. It was quite difficult, very, very difficult with the technology of this period to advance the valve through the bicuspid morphology. Finally, it was succeeded. And the final result was good, but we have a dissection. It was a small dissection treated medically. However, now data from the new generation TAVI devices have shown better results. No difference in mortality rate at 30 days and 1 year, and the stroke rate at 30 days still is higher in patients with bicuspid morphology. This is data from the STS-ACC TAVI registry using the SAPIEN 3 valve from June 2015 to 2018. 2,726 bicuspid aortic stenosis patients were treated with the SAPIEN 3 device. At 1 year, the mortality, all-cause mortality, was statistically better in patients with bicuspid morphology, and there was no difference in the incidence of stroke. These are more recent data from China in patients with bicuspid morphology type 0. This is a retrospective study from 28 centers with a follow-up at least 30 days. The technical success was 98%, all-cause mortality less than 1%, and the stroke rate 3.6. The imaging evaluation of calcium distribution and morphology is very, very important. The sizing, implant strategy, and depth based on CT are essential. These are data for the self-expandable TAVI device from the same registry, from 45,938 core valve procedure using the Medtronic platform. The first core valve, the Evolut R and the Evolut Pro devices have shown all-cause mortality that was low with Evolut R and Pro 2.4 to 3%, stroke rate between 3 and 5, and permanent pacemaker decrease from 25% with the core valve to 8 to 11.2 with the Evolut Pro devices. And the degree of paravalvular leak after device implantation, more than moderate, was low. On the same direction are the more recent Bivolux result from Europe. Valve performance at 3 days was 97.9%. Freedom from severe patient prosthesis mismatch at 1 year, 96%. And freedom for moderate to severe AR at 1 year, 98%, using the self-expanding Evolut devices. Recent data of TAVI versus surgical aortic valve replacement in patients with bicuspid morphology have shown no difference in hospital mortality, stroke, paravalvular leak, vascular complication between TAVI and surgical AVR. TAVI is associated with higher risk of permanent pacemaker implantation compared to surgical procedure, and a lower risk of acute kidney damage or any transfusion. At follow-up, median time to 81 to 84 months, there was no significant difference in all-cause mortality. You can see the data for 30 days and 1 year mortality using balloon expandable or self-expandable device, and compare to the surgical AVR procedures in all-risk patients. In low-risk patient, almost half, 30 days and 1 year mortality, and it was comparable to the mortality observed with surgical aortic valve replacement. This is the existing recommendations for TAVR in bicuspid morphology. To be patients with bicuspid morphology and symptomatic severe aortic stenosis, TAVI may be considered as an alternative to surgical AVR after consideration of patient-specific procedural risk, values, traits-off, and preference, and when the surgery is performed at an experienced valve center. But I think, based on the new data, it is the time to have a randomized trial, surgery versus TAVR for bicuspid aortic valve disease. So, in conclusion, dear Chairman, ladies, gentlemen, I don't know if it's correct, ladies and gentlemen, my dear. TAVI in bicuspid valve is feasible, but may be technically more difficult than the tricuspid valves. Results are comparable to the results of tricuspid valves. Paravalvular leaks may be more frequent. Rupture of the ascending aorta in patients with ascending aneurysm may occur. Oversizing of the valve should be avoided. Better results can be expected with better round. And with my thanks, I would like to show the beautiful city of our president, Professor Michalis. Thanks.
Thank you very much, Vasilis. Thanks a lot. That was a very nice surprise. Thanks a lot for your presentation that added all your experience to our knowledge. And I would like to ask Dr. Mavrogianni if she wants to make any comments or anybody else from the, okay, let's start with Dr. Karabinos.
Thank you for your great presentation. I'd like just to say that we saw last year a meta-analysis which confirmed what you have presented, that there is a drop between TAVR and SAVR. Regarding criteria to select patients, Yoon has shown since, I think, 2020 or 21, that in type 1 severs, if there is calcification of the RAF and burden of calcium over the leaflets are variables to predict mortality, higher mortality, if there are both of them, and if there is none of them, the mortality is very, very low. Severs, I think, is rather obsolete today. I mean, the classification of severs. It has been proposed that we should use either the truly bicuspid valve, which is the type O severs, type 1 severs, the presence of a RAF, and a new emerging category which shares some mortality, the partial RAF. We see a tricuspid valve, which is actually is not, and we may just, suspicion may rise since there may be an enlargement of the ascending aorta.
I agree with you. I'm not sure if the last category is true bicuspid valve morphology. And we have many cases, yes, many cases with calcifications between two RAFs, so you consider it's a functionally bicuspid valve morphology.
Thank you, Vasilis. Is anybody else who wants to make a comment? No, and with this, I would like to conclude our session and